instability today, and that's primarily we're talking about the labrum, but also the capsular, stabilizing capsular structures. So some people will divide instability into macro instability, which are basically dislocation, and micro instability. The macro instability typically involves the glenohumeral ligaments, tears of the labrum and the capsule, and bony changes that we'll talk about. Micro instability is a term that was kind of made popular by an orthopedic surgeon down in Orange County, and it really involves injury to the superior structures of the shoulder, and we'll talk about that a little bit too. So in looking at the glenohumeral ligaments, they are major ligaments that you're familiar with that help stabilize the glenohumeral joint space. And by the way, as I think you all know, the glenohumeral joint space is the most intrinsically unstable joint in the body. The glenoid is relatively small, the humeral head is relatively large, so it's a lot like a golf ball on top of a golf tee. Hence, it's commonly involved with instability. We already talked about the superior glenohumeral ligament on the previous lectures. The middle glenohumeral ligament tends to attach along the medial, the anterior aspect of the glenoid. And then the inferior glenohumeral ligament, there's an anterior band and a posterior band that attach along the inferior portion. As we'll talk about, the anterior band has a very variable location where it inserts, and sometimes that can be a problem in evaluating MRs. So it's important to recognize the normal and abnormal anatomy of the anterior band. If we do a cross-sectional image through the glenoid, this is the superior, this is inferior, we get this kind of image here, where here we have the subscapularis muscle and tendon. Here's the anterior capsule here, which is a thickened part of the anterior capsule is the middle glenohumeral ligament, anterior labrum, posterior labrum, and then the posterior capsule. So on an MR scan, this is typically what you see. Here's the humeral head, the intertuberous groove of the biceps tendon, the subscapularis, the middle glenohumeral ligament, anterior labrum, posterior labrum, and here's the posterior capsule back in this location. Superiorly, the anatomy gets a little bit more complicated. In the axial plane up here, this is really the superior part of the glenoid. We can see a little of the anterior superior labrum, the posterior superior labrum. This is a superior glenohumeral ligament coming over to here. And so there's really three structures that very commonly attach in this location. Superior glenohumeral ligament, this is the origin of the middle glenohumeral ligament, and then the labrum here. There's a variant, which we'll talk about, which is superior insertion of the anterior band of the inferior glenohumeral ligament, which can also stretch all the way up here and attach in this location also, which can sometimes be confusing. That's in the axial plane. And the sagittal plane here, we can see the superior glenohumeral ligament complex is up here. This is the middle glenohumeral ligament, which comes down and really attaches to the fibrous capsule of the subscapularis muscle here, and then to the glenoid, and then the anterior labrum there. So that's a labrum, the middle glenohumeral ligament, and this is the rotator cuff interval that you're all familiar with. And you have to have an interval here because you have to have space for the coracoid process here in anatomy. So anatomic variants that can be a problem here are the labral recesses, including sublabral foramen, the Buford complex, which is initially described at UCLA, and superior insertion of the inferior glenohumeral ligament, and there are a whole host of others less problematic normal variants as well. So labral recesses, these are somewhat controversial. Most people believe that recesses above the midline, the upper part of the glenoid, can be normal, but they should not be present below the midline. The interesting thing about it is that they're really not present in kids. They don't really develop until teenage years, and so some people believe that they're actually trauma, but most of the time above the midline of the glenoid, they may not be symptomatic or cause any problems. But they're generally above the midline, considered normal variants. So here's a coronal image This is the biceps anchor coming in here, which we can see there. Here we can see part of the articular cartilage. And then right in here, what we can see, this is the labrum. That's the biceps anchor. We can see a little bit of fluid extending deep to the labrum. Notice that there's no signal actually going into the labrum. So this is considered a normal variant, which is really a superior recess. And all the margins are nice and smooth here, nothing irregular. Sometimes these can be very large. This is a superior recess. Notice that the cartilage is normal deep to it. We have the labrum here. And there have been studies looking at the distance here and how big a distance can you have that can be normal. And most papers show that the distance here, there is no cutoff. Not 2 millimeters like some people said to begin with. What you want to see is if you have any signal going into the labrum, that signifies a labral tear. If it's just at the base here and you have nice smooth margins, irrespective of the distance here, it should be called a superior recess. So that's, on the axial images, it can look like this. Nice smooth edges, that's a superior labral recess. So here's a question here. Here we can also see a little bit of the labrum here, the big separation. Things are relatively smooth here. We see fluid going in that area. So what is this? If we extend more inferiorly, however, so here are the axial images, this is the area of the recess. But if you go down, you notice that this actually ends up going into the labrum itself. Here's the articular cartilage. This is the base of the anterior superior labrum, and this is actually now a tear going into the labrum. So if you can follow it and it ends up clearly going into the labral structure, then it's really a labral tear. And then if we go a little farther down, it ends in that location. So this is really a slap tear, superior labral tear, which we'll talk more about slap tears later. Alrighty, let's see. Thomas, what do you think of this case?
52-year-old male, increasing pain for 9 months, evaluate for impingement. So you have a coronal and an axial view, and the biceps labral complex looks degenerative. I don't see a sulcus or a tear,
Okay.
but just intermediate signal of the
So here's
biceps labral.
the biceps there, a little demarcation between that. Here would be the superior labrum. This is probably the articular cartilage, not the greatest images, but not atypical of what we can see. Probably a little motion artifact. And here we can see a little bit of recess coming in here, the anterior superior portion. So this was on 6/18/05, and now the patient came back on 12/20/07. What do you think here?
So this looks like an arthrogram.
Okay.
And yeah, I mean, we see the sublabral recess, kind of well delineated, smooth margins. There's no signal going into the superior labrum, so that would just be a normal recess.
And here's some other images here. I have to be a little concerned when you have a fluid over here, but we'll talk about that later. Here we can see what could be a recess. So this is 12/20/07. So this was called a superior labral tear. Okay, that was called. Okay, then the patient came back 10 months later and had this study. What do you see here?
So yeah, there's some fluid there. I'm not sure if it's an arthrogram, but still looks pretty similar. There's a little bit of signal, but it's still smooth margins and no signal extending into the labrum.
And then here's the axial image.
So the axial, so I see the middle glenohumeral ligament sort of just deep to the subscap, and then there's another structure there anterior to the, oh, so they must have had a repair, I guess?
Okay, so they had a suture anchor repair. The patient continued to have symptoms that were unchanged after the repair, and this ended up being a surgical repair for superior recess. So about 10 years ago, slap tears were all the rage, and everybody was calling them. We'll talk about the 10 or 11 different types of slap tears later, in, if not this lecture, the next lecture. And a lot of surgeries were performed in this particular area. And then there was a paper that came out of San Francisco showing that actually the patients did worse if they had surgery, because a lot of surgeons would over-constrain the superior glenoid and they would superior labrum, and they would end up having increasing symptoms. And then there became a bit backlash where people really stopped doing slap repairs. And now people are interested in it. It's very commonly known. Slap tears are in the athletic areas. Everybody, or all the kids know about slap tears. So it's important to describe them, but the vast majority of slap tears should not be repaired. So, you know, if there's a concern about the two, you can describe it, but I would err on the sides of calling it a recess rather than a tear, because a lot of people ended up being worse after being repaired. Okay.
Was there a posterior labral tear on the previous slide?
I don't see.
It was the, I guess, the very last image.
Here?
I think it was the last image that you showed.
That's how we have it. I don't remember.
Okay.
So, this one?
Yeah, I think it was there.
Here?
Yeah.
I'd like to see other ones.
Maybe.
I don't think so.
Okay.
Okay. So, Sam, what do you think of this?
So looking at the labrum, looks okay. I mean,
Okay, that's at the midline. And then here's below the midline.
right. So anteriorly it looks a little bit rounded.
This, you mean here or
Yeah.
here?
And deep to undercutting is a little bit of
Yeah.
linear signal.
So there's fluid going deep to it in that location. And above the midline, that's considered a normal recess. Below the midline, you have to be much more concerned about it.
Yeah.
And here we can see this extends all the way to the inferior labrum, but it's not really going into the labrum itself. At arthroscopy, this was thought to be an injury to the labrum, which was a little bit loose, more loose than it normally should be, but the actual labrum wasn't torn. So they ended up not repairing it, but they thought it was not normal. Okay.
Okay. So it looks like I see a sort of curvilinear hyperintense focus, the anterior labrum, right in there. It looks to me like, is the part just anterior to the arrow part of the labrum with periosteum sort of still intact there?
So you're talking about this?
Yeah.
Okay. So actually, yeah, this is the labrum.
Okay.
This is the normal attachment here. And in the anterior superior part of the shoulder, there is commonly a defect in the labrum, which is called a sublabral foramen. Mm-hmm. And it's like this, and then usually the overlying labrum gets very small right in that location. And that's really considered a normal variant. Mm-hmm. And then what's this structure here?
IGHL.
Yeah, that's the middle glenohumeral ligament. So there's a middle glenohumeral ligament, labrum, here's the bone, and that's the sublabral foramen.
If this was below the equator, then would you call it part these? Yeah.
Yeah.
Okay.
Yeah. So here's the case. Here's a biceps tendon, superior glenohumeral ligament. When we come down here, here's probably the middle glenohumeral ligament, which is somewhat thickened. And here you can see the middle glenohumeral ligament coming down here on the coronal images. The next axial image down, we can see this here, but we don't really see an anterior labrum. Here the labrum is very small, but if you follow this structure, it goes over to the capsule, so that's the middle glenohumeral ligament, but there's a deficiency in the labrum. Here are the coronal images. We can see a big thickened middle glenohumeral ligament, and here on the sagittals we can see a middle glenohumeral ligament coming down to attach to the capsule deep to the subscapularis. Uh, so, uh, so this is the Buford complex. First described, I think, about 2% of cadavers. But Buford, I think, was a fellow at that time at UCLA, is what some people have told me. Found this out, and these are basically stable lesions, and shouldn't be interpreted as a displaced tear. That can be the problem. Is this may not be recognized as the middle glenohumeral ligament, and therefore could be misinterpreted as a tear. So it's an important complex to be aware of. Okay, Sahar, what do you think of this case?
Okay, 28-year-old female, 8-month post-labral repair. So the label looks okay on these two images.
Another cut. There's another cut. There's another cut. Oh, that cut there. What are those two structures?
So the red arrow is pointing to the labrum, which is very small, maybe absent, and the yellow one is pointing to the medial glenohumeral ligament, like a Buford complex.
So what do we see here?
So here the labrum is totally absent. Oh, they did a repair.
Okay. Yeah. Okay. And then here's the defect here. So this was, and here we can see the middle glenohumeral ligament coming up in this location. There's a superior labrum with a recess in that location there. And here's the suture anchor that we saw before. So what happened here? What's going on?
So they repair for tear or something.
Yeah. They did a repair of a Buford complex. And the patient came back with the same symptoms they had before. So this initially was called a labral tear, so they operated on it, and the patient came back, and this was just a Buford complex with a superior recess. So the interpretation by the radiologist is important.
How do you repair it? There's nothing there to pin down.
Well, you've got a superior recess, and if it's called a tear, you see a small labrum there. They thought this was a displacement. When they went in there, they could pull up the labrum a little bit because there's a superior recess, and they put in a suture anchor. Yeah. And this is one of the reasons why these slap-type tears, these superior labral tears, are really not repaired as much now because these patients didn't do as well. Okay.
I wonder what they were repairing.
Yeah, that's just what Sam asked, John. Yeah, I think they were repairing the superior recess here.
Yeah. Well, but it doesn't go to the recess, or at least it doesn't look like it goes there.
Yeah, right. Okay, next case. Thomas, what do you think of this case?
20-year-old baseball player with shoulder pain, evaluated for a labral tear. So we have an axial view, I think fairly superior on the glenoid. I'm not getting a good view of the anterior labrum, and I see, yeah, maybe, I guess,
If you have a small anterior superior labrum, then what do you think about?
that could be, they're associated with variants, so you can have a small anterior superior labrum when you have a superior attachment of the anterior band, and I believe they're also associated with some other variants also.
What's the variant we're talking about right now?
So I don't see a cord-like middle.
There's the cord-like middle glenohumeral ligament.
Okay.
But what's
So
wrong with it?
yeah, so this would be a Buford complex with a tear of the IGHL.
Okay, and then here we can see the middle glenohumeral ligament looks abnormal there. We can see basically the absence of the anterior superior labrum. And there we can see, so this was and there's the middle glenohumeral ligament coming down there, a big thickened cord-like middle glenohumeral ligament. And this was a Buford complex with a tear of the middle glenohumeral ligament. Because with the Buford complex, the middle glenohumeral ligament kind of takes over the stabilizing structure for the anterior superior part of the joint space. So if there's strain there, it's the middle glenohumeral ligament that tears rather than the labrum.
And after fall injury, catching himself while falling. So actually, this is a bit of bone. Looks like broken off from the anterior glenoid.
Are you talking about this?
Yeah. Yeah.
Well, why do you say it's bone? I mean, we just have one image there. But it's happening over here.
It also looks like bone to me.
So we're talking about that.
Yeah.
So let's look at some other images here. That's the sagittal. It's like probably a T2. This is what it looked like at arthroscopy. So this was a tear of the middle. So this was not bone. This is the middle glenohumeral ligament that's torn right there. And the glenoid is right here. And this is the tear in the middle glenohumeral ligament right there.
Okay.
So here's the middle glenohumeral ligament coming down. It's not taut like the others we saw. This is the tear. And this was surgically confirmed. Okay, now this was a potential #1 draft choice. And this was the axial MR scan through the shoulder because the patient was asymptomatic, but the team got an MR scan. And the question asked me is there a labral tear here? Because it was called a labral tear, and a lot of teams decided they weren't going to draft someone who had a labral tear. So what do you think?
So I see a thin, hyperintense linear focus in the anterior labrum.
Okay, so let's look at a bunch of images here. So there are a series of images.
Okay, so looks like that third image was the one we were just looking at.
Okay.
And then inferior to that, it looks like the MGHL is a little thick. And then superior to that.
Okay. So is it torn?
I'm going to say no. I think that's the MGHL.
Okay. Yeah. So this was a cord-like middle glenohumeral ligament. And you can see that the labrum is there, but it's a little small. But you can see this is a thickened middle glenohumeral ligament. It comes down there, and it goes to the capsule. It doesn't go back to the labrum. If this were a labral tear, if we go far enough down, we'd see it fusing with the labrum, or it'd be flapping out in the breeze. It wouldn't fuse with the anterior capsule. So this was a cord-like middle glenohumeral ligament, and once that diagnosis was made, he actually ended up being a #1 draft choice. So this was a near miss for being a significant issue for this player. And this is, I think this is.
Did he tip you, John?
No, I never saw him, but the orthopedic surgeon liked it. And so here's the plane with that image was in that we're concerned about. On the sagittal, you can clearly see that this is the middle glenohumeral ligament coming down. So it's important to know this. Oh, you know, actually, this was a different patient. This wasn't a #1 draft choice, but this was an athlete where that was called a tear, and it turned out just to be a misunderstanding of a cord-like middle glenohumeral ligament. This next one is the #1 player. Sorry. Okay, so Sahar, what do you think of this case?
Okay, congenital labral tear, college prayer, possible #1 draft. So there is some irregularity of the anterior aspect of the labrum, and there is like a triangular structure just posterior to that.
Okay.
Which,
so this is someone who was the story I gave before. Sorry about that. This was an asymptomatic shoulder, someone, or minimally symptomatic, but they did an MR scan before the draft, and this was called a tear. And this is the area that we're concerned about. So what do you think is going on here?
I think the labrum is okay. Is it part of the MGL that's
Well,
Then we see
here's the middle glenohumeral ligament here. So it's not like the last case. So we've got two structures there. Now, if we start below, this is down below, and what we see here's the anterior band of the inferior
oh,
glenohumeral.
okay.
And if we follow that up, this is the anterior band of the inferior glenohumeral. Here's the anterior band of the inferior glenohumeral ligament. There's the anterior band of the inferior glenohumeral ligament, and there's the anterior band of the inferior glenohumeral ligament. And if we go to the sagittal images, there's the anterior band of the inferior glenohumeral ligament. There's the middle glenohumeral ligament.
Mm-hmm.
So what is this?
High attachment of the anterior band of the inferior
So
glenohumeral
this is
ligament.
a superior insertion of the inferior glenohumeral ligament, which if you're not aware that this is a normal variant, can be misinterpreted as a labral tear. So this is the person who ended up getting his #1 draft choice. Okay, so labral tears, we'll talk about some technical aspects, some anatomic variants, and different tear types. So we've already talked a little bit about the ABRA view. Again, this was initially conceived by Philip Tierman as a way to kind of put the shoulder above the head and internal rotation and put traction on the anterior labrum to try to increase visibility of the anterior labral tear. And here's a case where we really didn't see a tear on the regular views, put them in the ABRA position, and we can see the tear there. That kind of opens it up. We then did a study looking at this, and what we found is a few percent of the time we could see the tear in the ABRA view. A little bit more percent of the time we could see the tear in the regular views, not the ABRA view. So the ABRA view can sometimes be helpful, but we basically felt, that the ABRA view wasn't that valuable for the anterior labrum, though sometimes it can help. But we'll talk a little bit about how I think it can be helpful posterior superiorly. But the bottom line is we only do the ABRA view in young athletes when we do arthrography. And anyone over the age of 35, I haven't found it valuable at all. But in some of the young athletes, it can be helpful, especially if they're pitchers or overhead throwers, because it can help us really evaluate posterior impingement that we talked about before, more so than the anterior labral tears. But a lot of people routinely do these on arthrograms. It doubles the time of the scan, so it's the techs and the centers don't really like it. And patients don't like it either because for people who have actually shoulder symptoms, the ABRA position is a very painful position. So I only like to use it when I think it's really going to has a high likelihood of being valuable. Because you have to take the patients out, rescan them. After you reposition them, you have to redo the scouts and you have to do special angles. Okay, Thomas, what do you think of this one?
Shoulder pain, evaluate for a labral tear. So we have two axial views, and the posterior labrum looks intact. The anterior labrum is a little bit, intermediate signal. I don't see a definite tear.
Yeah, so this one, we put this patient then in the ABRA position, and this is what it looked like in the ABRA position.
Okay, yeah, so there's a little bit of fluid undercutting the base.
Yeah.
Labrum.
Yeah, so, and then here the ABRA position, this is one where it worked out the way it was planned, where it actually pulled on the labrum and opened up the tear so you could see that this was a tear. So that showed displacement of the tear on the ABRA view. So this was one of the few that we had in the study where the ABRA view showed the tear. It was a little bit iffy without it, though you can certainly see that there's some increased signal intensity at the base of the labrum here. It's basically the contrast is being absorbed by the abnormal tissue here, even though there's no displacement of the labrum. So this is one where the ABRA was actually helpful. Okay, let's see. Sam, what do you think of this one?
Anterior labrum is irregular. There's a structure just anterior to it, which I guess is either going to be a ligament or probably a ligament.
Well, actually, so here's the anterior labrum, and there's a signal at the base of the anterior labrum, right?
Yeah. So
whereas it's a normal posterior. So I would be concerned about a tear. This patient was put in an Aber position, and this is what it looked like in the Aber view.
It doesn't show as
Yeah,
well.
here the Aber really didn't help all that much. It almost looks like it's intact here. This patient actually went to surgery, and it was a tear. And we actually confidently called the tear on the non-Aber views, but once we got the Aber views, we weren't so sure of it anymore. But he went on, and surgically it was torn. So there are a number of different signals. This, if you notice in this particular case, this is bone, and we can see a little chemical shift artifact here. The articular cartilage goes right along the bone here. Notice here there's high signal intensity curving around the base of the labrum in continuity with the articular cartilage. And this is usually normal when that occurs. If you have linear signal outside that area in the labrum itself, that's an indication of a labral tear. Here we have two signals, the cartilage and another signal here that wraps around. That's a labral tear. And here we have a signal going in a perpendicular direction, and that's a labral tear. So this is actually normal, and the other three were all confirmed labral tears. So now the osseous anatomy is very important for evaluating instability. Typically, the humeral head has about 20 to 30 degrees of retroversion, and then we can kind of see articular surface. The glenoid, which is what we're generally more commonly really evaluate, is typically pear-shaped in 90% of individuals, also kind of a small section and a large section. It's ovoid in only about 10%. And here we can see, as we talked about before, it's like a ball on a tee, a golf tee, intrinsically unstable. There are a lot of ways to look at version. The glenoid version is relatively important. This is obviously abnormal, and I'll show in a minute, I think, how we can do angles to evaluate this. But this is severe retroversion, and this is usually a congenital anomaly, but it's usually associated with a very large posterior labrum, which we'll see on some of the studies. And this is a very unstable shoulder, because a lot of the use of the shoulder really puts forces on the anterior aspect of the humeral head. So you need the posterior bone here to stabilize the humerus. And so this is a very unstable, congenitally unstable joint. And that often leads to degenerative disease because these people become unstable, and it's a tough thing to treat surgically. John, do you want to make any comments about retroversion?
Well, not so much. It's a congenital anomaly, and obviously the function is abnormal for the individual in terms of moving the arm forward. What I was going to say is there's only 20% contact between the head and the glenoid for a normal shoulder.
Yeah.
So it's like you say, it's a T. Some people say it's like a ball on the nose of a seal.
Okay.
So then when you add the labrum, then that increases it to 50% contact. So that's improved, and but it's still the suction that you get when you try to pull the shoulder out of socket. That is a very relatively minor amount of holding the head in a socket. That's what Campbell's describes, but actually it holds the head pretty well, because you can have the forequarter and cut all the ligaments and tendons, and you've seen this at meetings,
yeah.
I'm sure, and you can hold the arm and the upper body will just suction of the head in
Yeah.
the socket.
So some people,
And then you can remove it by lever and then put it back and hold it, pull it up again, and through different sessions of the meeting.
yes.
So it's I don't know why Campbell says it's not. It's a relatively minor uh, position.
Yeah. So some people
They do.
some people believe that one of the problems you get into with labral tears is the fact you lose this section mechanism that John's talking about, and that leads to people more likely to be unstable because you don't have the suction holding the humeral head in place. Right, John? That's what you're talking about.
Yeah, that's a congenital stuff, though. So
Well,
there's so many differences, and that's the interesting part about orthopedics. That everybody is different.
okay.
So
Sam, what do you think of this next case?
I think there's been surgery here.
No, no surgery.
Well, there's appears to be a really sharp line through the glenoid. It's abnormally shaped. It's very,
You're talking about this?
yeah.
I don't think it's through the glenoid, but here we go, right through here. So what is
tiny,
this?
just a tiny.
Okay, so here's the glenoid, right here. Okay, what's this?
Okay.
What's this?
Right. That's a labral tear.
Okay, yeah. So this is congenital instability, as John and I have been talking about. This you have a severe retroversion. You have really a poor development of the glenoid and a very large posterior labrum. And these are very unstable, and the tears occur here very frequently. And these patients don't do well as athletes. This is a severe example. So here we can see that this would be the kind of the normal glenoid, and it's usually a little bit more anteriorly anteverted. And this would be varying degrees of flattening of the posterior glenoid with enlargement of the labrum, which lead to congenital instability. And this doesn't show the retroversion that's usually associated with the anomaly on the right-hand side. So just like that last case. Shiv, what do you think of this case?
25-year-old man with chronic instability. So here it looks like there's posterior dislocation of the humeral head relative to the glenoid, and the glenoid looks retroverted, and the posterior glenoid is rounded and blunted.
Right. So this is another case of congenital dysplasia with congenital instability. Okay. Sahar, what do you think of these plain films?
Okay, so there's a bone remodeling of the humeral head, and also I see some ossification superiorly.
Yeah, these are all for chronic instability and ossifications. And this was a case also of congenital dysplasia, where even multiple plain films, you can't really see it real well, but you don't really see the normal anatomy of the humeral head and glenoid here. And that was congenital dysplasia. And this is what it can look like on MR examination. Again, on this case, we have a very abnormal dysplastic glenoid and obviously an abnormal head as well with all this effusion and pathology around it. These are cases of kind of severe dysplasia. Okay, Thomas, what do you think of this case?
So an axial view of the glenohumeral joint. The posterior labrum looks like it's intact, and there may be some spurring posteriorly, and then the anterior labrum, a little bit of intermediate signal at the apex. Yeah, I'm not seeing any fluid undercutting the
And
labrum.
here's the CT. What do you think on the CT? Oh, I'm sorry, the T1, excuse me.
Yes, on the T1, so yeah, the posterior labrum looks blunted, and the anterior labrum I'm not seeing well, and there's spurring of the anterior glenoid rim.
That's not a CT.
No, it's not. It's a T1.
So it looks like the anterior labrum's kind of replaced by anterior spurring of the glenoid.
Yeah, I wouldn't say it's replaced. I think that's ossification of the anterior labrum. And the inferior,
Okay.
which we can see here. Here's the CT. Sorry about that.
So on the CT, yeah, there's kind of the labrum's kind of replaced by ossification in the.
So you can get ossification of the labrum, and in this case also the inferior glenohumeral ligament, which is a degenerative phenomenon which can occur. And on the PD fat sets, you may not really recognize it very well, but you can see it on the T1s and the CT. So it's ossification, right?
Is it symptomatic?
What?
Is it symptomatic? I mean, what stabilize?
Yeah, well, it's indication of long-standing degenerative disease of the labrum, and I think it's important to point out because it indicates that there's degenerative disease and to the surgeons. Yeah. Okay, and then labral tears. We can talk about it. We'll start with the anterior labral tears, and there are a lot of different names for the different types. There's a Bankart lesion, a Perthes lesion, an ALPSA, and a gland lesions are very common ones that people talk about. These are associated with anterior instability due to anterior displacement of the humeral head with respect to the glenoid. And you tend to get a Hill-Sachs fractures and also Bankart lesions with this, and a bunch of anterior labrums. And then these typically can be repaired, especially if they're in the young athletes. So the mechanism of injury is an anterior displacement, and the muscles contract and forcefully contract the humeral head back against the anterior glenoid, which produces a typical Hill-Sachs impaction fractures that you've all seen, first described in 1861 by Flowers, and then later in radiology by Hills and Sachs in 1940. And this is an example. This is plain radiographs where you can see an anterior dislocated humeral head, and you can see the mechanism of impaction of the glenoid against the humeral head, producing the Hill-Sachs impaction lesion. And here's the CT scan of that patient, showing the mechanism of impaction of the humeral head by the glenoid in the dislocated position. And here's the MR scan in that same patient. I don't know why they did all this imaging without putting his shoulder back into position, but they did. So this is anterior dislocation. And then here we can see the dislocated shoulder in the coronal plane with a lot of capsular and other injuries here.
Maybe the patient was unconscious.
Yeah, I don't know. This was in Korea, from Dr. Su. Here's just a plain radiograph, so another anterior dislocation with some bone fragments that we always need to look for, really in the acute setting. And here there's the glenoid, and we can see the anterior-inferior displacement of the humeral head. This was prior to reduction, and here's after reduction, where we can see the humeral head back in normal position, but a very large Hill-Sachs impaction injury here. Okay, let's see, who's next? I think Sam. What do you think of this case, Sam?
On the image on the left, I don't see the humeral head. On the image on the right, I guess we moved anteriorly, and then we do see the humeral head, so it's anteriorly dislocated. Okay. And yeah, it's acted on the anterior glenoid.
Okay, so this is the acute Hill-Sachs impaction and the typical mechanism. This is an anterior dislocation. Okay, so and here's typically what we see by the time they get to MR scanning is that the humeral head's back in normal position. Here we can see the typical V-shaped impaction injury, as well as a bone marrow edema around it, consistent with an acute lesion. Back in the days when we used GRE at Highfield, we don't see the bone edema. We still do the GRE at low fields because we get a little bit better spatial resolution with it, but it's not sensitive for bone injury. And there's acute Hill-Sachs. Here's what it looks like on the coronal T1 and PD fat-sat images. This was, okay, so this was from Brazil, and we can see displacements there, and then a big fracture. Okay, so this was a patient who had an anterior dislocation, which we can see here. And then they tried to relocate the patient, but they had difficulty getting the shoulder back in relocation. Normally you can pop it back in pretty readily. So here the plain film, CT scan, and here we can see some of the bone changes. Here's the big Hill-Sachs injury back there. But notice on the CT scan, there's still a lot of separation here in the glenohumeral joint space. So what do you think's going on here, Shiv? Why can't they get it to relocate properly?
Could it be because there's an effusion there, and it's sort of?
Well, the fusion wouldn't keep you from relocating it.
What's that dark thing? Things.
Oh yeah, okay. There's something's in between the joint space and the glenoid.
Yeah, what do you think it is?
It's not the MGHL. Could it be the posterior inferior?
Well, what's a nice black structure like that? That
could be there.
Yeah, a second here. What's going on here? What is this good for?
How about the biceps?
Yeah, and here's the
There's
a coronal image. That's a displaced biceps tendon there, which we can see going on.
Okay.
Yeah, so the biceps kept them from being able to relocate it. So you
and long head, of course.
Mm-hmm.
Yeah, long head of the biceps, right? Okay, Sahar, what do you think of this case?
30-year-old male with pain and clicking and abduction to 90 degrees after surgical reconstruction for dislocation. So looks that there is some Buford and Hill-Sachs deformity of the humeral head. And
well, so here's the Hill-Sachs. We can't really see the Buford here. The Buford we haven't gotten to yet, but that would be the inferior anterior aspect of the glenoid. And I don't think
very superior. Okay. And maybe on the subscap.
So what's happening here?
Okay, so there is actually some deformity of the anteromedial humor. It's like a reverse Hill-Sachs.
Well, what's happening here is that they're placing the patient in the position where they have the pain, and what's happening is that the glenoid is engaging into the Hill-Sachs lesion. So the cause of the pain and the clicking is the fact that the glenoid is falling into the Hill-Sachs lesion, and that can produce a lot of irritation and abrasions of the labrum and the articular structures here. So you don't want this to happen. If they're in a position where they engage, they get a lot of symptoms. And so what we now do, and several of you have done it, there are measurements that we can make where we can predict whether or not a lesion was likely to be engaging. And if so, when they do the repair, they will do it differently. They'll either put in some bone in this location, or they'll do what's called a remplissage, which they'll bring capsule down and attach it to the humerus here, so which does not allow them to rotate into the engaging position. And then they have limitation of motion when they do that, but they don't engage and they don't get a lot of the pain.
Sorry, that's the posterior humeral head?
Yes, this is, they flipped him over. They flipped the patient over and put his arm up.
So they bring the...
so this is anterior and that's posterior.
They bring the infraspinatus and pin it down, or you said
the capsule. They bring the capsule and tack it down, called a remplissage procedure. I think we'll talk more about that later.
So when we say engaging, we're engaging onto
the glenoid.
Anterior glenoid.
The glenoid is falling into...
I'm sorry, into the posterior.
Right, posterior glenoid, right. Okay. Let's see. So now When you do an MR scan in someone who has dislocation, especially if it's recent or especially if it's the first one, you look for a number of things with the glenoid structure. You look at the glenoid to see whether you have abnormal version, whether you have a congenital problem. You look for fractures, and typically the fractures on the glenoid would be the anterior-inferior glenoid, or what we call Bankart fractures. And if you have a fracture there, it's important to determine the percent of the glenoid width that is involved. So you draw a line across here, a line through the fracture, and see what percentage it is. If it's 25% or greater, then if you're going to try to do a surgical stabilization procedure, you have to do something to treat the bone defect because you don't have enough glenoid left to be stable in that position. And we'll talk about some of the procedures to do there. And then on the humerus, we look really for the Hill-Sachs lesion, the size and its location, and we try to determine then whether or not it's a large enough size so if they go through and become a normal functional position, whether it will engage or not. If it's engaged, that means you have to have a special surgical procedure to keep that from happening. And we'll talk more about that later. And then you also look for chondral injuries, and then obviously any structures that may be in the joint space that may inhibit you from being able to relocate it. And then this is just a labrum. So actually, let's see. Okay, who had the last one?
Zahar.
Zahar. Okay, Thomas. What do you think of this one?
53-year-old evaluated for labral tear. So I see
12. Here's this cut. There's the next cut up. There's another cut. Here's another cut. There's another cut. And now we're all the way up here toward the top.
Right. So I think looks like there's an anterior labral tear.
Go back here. Here, certainly this is suspicious right here.
Yeah.
And then you got this thing right there, and this right there as well. This might actually be bony here, and then up, and then we got signal there. So that's 8/20/2012, and this is 10/18/12. So this is 2 months later. This is an arthrogram. What do you think of the arthrogram?
So yeah, so there's a little structure anterior to the glenoid rim, which I don't think is the anterior labrum. So that might just be anterior band, and that linear.
Got a little loose body back here as well. But we just signal there, and we don't really see the fluid going in here very well, but there is a deficiency here, and we're still below the equator at this location, and this is contrast extending through the base out into a little perilabral cyst. And here it's even larger. Now we're getting up a little higher, but this is a tear. So this is an anterior labral tear. You can see it with and without an arthrogram. Okay, Sam, how do you think of this case?
So the axial images show two things. First of all, there's posterior humeral head contusion of marrow.
Yeah, so a typical Hill-Sachs lesion here, relatively acute. And then if we go down farther down below in the axial plane.
So the glenoid's not normal. It's flattened, kind of
a little bit
there anteriorly.
And what's this?
That's a labral tear.
Yeah, so that's a labral tear. So this is an acute Hill-Sachs with a labral tear. And here we can see another acute Hill-Sachs lesion with a bone edema, typical V-shaped appearance of it in that location. And here we can see the labral tear where the labrum is displaced, the abnormal configuration, and we also probably have stripping and tearing of its periosteal attachment in that location there. And this is now, let's see, this one.
Yeah, that looks chronic, then, John.
Yeah, the Hill-Sachs is acute. I'm not.
Oh,
It's probably
glenoid.
dislocations. That's right. Okay. And here's another case where we have acute bone edema, and this is what it looks like later. So this is the acute injury, and this is what the Hill-Sachs looks like later when it heals, and we just have kind of the V-shaped impaction. Okay. Okay, I'd like to stop here, and we will continue this at the next meeting. Okay. Thank you.
Thank you.
See you Thursday.
Okay. See everybody Thursday. Thank you.
Thank you.